Hi, my name is Lane Rehart, and I'm currently a PGY2 Critical Care Pharmacy resident at Prisma Health Richland in Columbia, South Carolina. The research project I'm presenting today is entitled Evaluation of Vancomycin Pharmacokinetic Alterations in Patients with Hemorrhagic Stroke on Concomitant Hypertonic Saline Therapy. I'd like to thank my co-investigators, Erin Creech and Allison Wilder, for their help with this project, as well as Dr. Martin Durkin for his help with the statistical analysis. The objective of this presentation is to describe the effects of concomitant hypertonic saline therapy on vancomycin pharmacokinetic or PK parameters in patients with hemorrhagic stroke. Hemorrhagic stroke includes intracerebral hemorrhage or ICH and aneurysmal subarachnoid hemorrhage or SAH. Patients with hemorrhagic stroke generally have longer hospital stays and may require mechanical ventilation or extraventricular drains, all of which increase their risk for hospital-acquired infections. Pneumonia occurs in almost 6% of patients with ICH, and ventriculitis occurs in up to 26% of patients with EVDs. And because of the hospital-acquired nature of these infections, patients often require vancomycin therapy. Previous case reports and retrospective studies have shown that patients with severe traumatic brain injury, neurosurgical patients, and hemorrhagic stroke patients have augmented vancomycin clearance. Anecdotally, patients on concomitant hypertonic saline have demonstrated even more pronounced augmented vancomycin clearance. It is known that sodium reabsorption and excretion occurs via active transport and passive diffusion along a concentration gradient in the kidneys. So theoretically, as the serum sodium concentration increases, the filtration and excretion of sodium in the kidneys increases as well, and so would the excretion of renally eliminated medications like vancomycin. Based on this proposed interaction, we developed a study to evaluate vancomycin PK parameters in neuroscience intensive care unit, or NSICU, patients with hemorrhagic stroke on concomitant hypertonic saline therapy. This was a single-center retrospective cohort study including adult patients admitted to the NSICU from January of 2018 to January of 2020. Patients with ICH or SAH and at least one appropriately timed vancomycin trough were included. Appropriately timed was defined as a trough obtained within 2 hours of the correct time based on vancomycin frequency and prior to at least the third dose of vancomycin. Patients with acute kidney injury or renal replacement therapy were excluded, and patients with changes in their hypertonic saline therapy between the time of the first vancomycin dose and the first vancomycin trough were also excluded. Baseline characteristics and PK parameters were collected at the time that vancomycin therapy was initiated, and data was collected until a maximum of 3 troughs were obtained. Patients were censored if an AKI developed, hypertonic saline therapy was initiated or discontinued, or if vancomycin was discontinued prior to 3 troughs being obtained. The primary outcome was the difference between the predicted and actual vancomycin elimination rate constant, or KE, and half-life. Secondary outcomes included the AUC to MIC ratio achieved with vancomycin therapy, the frequency of vancomycin administration, weight-based daily vancomycin requirements, and estimated creatinine clearance based on vancomycin clearance. For the baseline characteristics and all outcomes, categorical data was analyzed using Fisher's exact tests, and continuous data was analyzed using Wilcoxon rank sum tests and t-tests. Over the 2-year study time period, a total of 639 vancomycin orders for NSICU patients were eligible for inclusion. The most common reason for exclusion was duplicate orders within a single course of vancomycin therapy, and the second most common reason for exclusion was a lack of a vancomycin trough due to rapid de-escalation. Ultimately, there were 75 patients in the control group and 3 patients in the hypertonic saline group. Overall, about half of the patients had an ICH and half had an SAH. The baseline serum creatinine was relatively similar between both groups, and the baseline serum sodium was 144 in the control group and only 149 in the hypertonic saline group. Important differences that may impact vancomycin clearance are the younger age of the hypertonic saline group, the higher creatinine clearance in the hypertonic saline group, and the significantly higher urine output in the hypertonic saline group. This table shows the vancomycin pharmacokinetic parameters at the time of the initial vancomycin consult. The creatinine clearance used for PK parameters was again higher in the hypertonic saline group. The predicted trough was about 15 in both groups, and the predicted AUC to MIC ratio was similar, around 550 in both groups. At the time of the first vancomycin trough, the serum creatinine was again similar between the groups, and the urine output was again significantly higher in the hypertonic saline group. As expected, there was a clinically significant difference in serum sodium at this time, with a median of 145 in the control group and 156 in the hypertonic saline group. Although not statistically significant, there was a clinically significant difference in the mean vancomycin trough as well, with a mean trough of about 12 in the control group and 8 in the hypertonic saline group. The median actual KE was significantly higher in the hypertonic saline group, and there was a trend towards a shorter half-life in the hypertonic saline group. And although not statistically significant, there was also a greater difference between the predicted and actual KE in the hypertonic saline group. One of the secondary outcomes analyzed was the predicted versus actual AUC to MIC ratio achieved with vancomycin. The predicted AUC to MIC for each group, shown in pink, were similar between the two groups. However, the actual AUC to MIC ratio at the time of the first trough, which is shown in orange, was clinically different between the two groups, with an AUC to MIC of 456 in the control group and a subtherapeutic AUC to MIC of 315 in the hypertonic saline group. While the study does provide interesting preliminary data, an important limitation is the small sample size. Because of the sample size, our ability to find a significant difference in our outcomes was limited. Additionally, we were unable to perform any regression that would account for other factors that might influence vancomycin elimination, including age, creatinine clearance, and urine output. Another limitation of the study was the retrospective nature. Lastly, the study also does not provide information on the duration of the impact of hypertonic saline therapy on vancomycin elimination. For example, a patient's serum sodium may remain elevated for several days after stopping hypertonic saline therapy. So in theory, vancomycin clearance may still be augmented in this patient. Overall, the study demonstrated trends towards more rapid elimination of vancomycin than predicted in both the control and the hypertonic saline groups, and this is consistent with existing studies performed in hemorrhagic stroke patients. In patients on concomitant hypertonic saline therapy, there was a trend towards more rapid elimination of vancomycin, with a larger actual KE, a larger difference between the predicted and actual KE, and a shorter actual half-life. Lastly, larger studies are required to confirm these results. My assessment question is true or false. The investigators hypothesized that in patients with hemorrhagic stroke, concomitant use of hypertonic saline is associated with reduced clearance of vancomycin. And this statement is false. I thank you for your attention and look forward to answering any questions in the live session.